I feel very honored to be in this group of speakers. It was excellent. It really set up the sort of the crux of my talk today. And so these are my disclosures. And for some of the goals of this talk, I hope we accomplish in the next 20 minutes or so, just a very brief review on the psychosocial impact and impact on quality of life of IBD on children and teens. And again, a lot of my fellow panelists here have actually done a great job, so we won't have to spend too much time on that. Really focusing on the transition of care in the young adult IBD patient population, which I think is highly relevant to each and every one of us in this room. And then trying to determine what type of sort of measures or markers we would utilize to determine when our young adult patients are ready to transfer to adult GI care. And the answer is not automatically age, as we will find out. So looking at some potential measures that we can use to look at transition effectiveness, potential clinical tools or educational tools that we can use to really help prepare or equip our patients better to navigate into the waters of the adult world. And then finally, some approaches that we should actually talk about as a group in terms of the transfer of care process, as we will discuss, is different from transitioning. And it's kind of funny, I realized I kept this slide in as I'm standing on this box. And so children with IBD are certainly not small adults. And in fact, we have to remember this not only medically, but psychologically as well, because then I would certainly be in trouble in multiple respects. And so let's again very briefly do a synopsis of how we see our kids with IBD coping. And again, we had the beautiful abstracts yesterday and then the talks today. And so we know that it's a huge issue. And so Dr. Sigathy and colleagues have looked at the prevalence of depression in children with IBD, and we know that often factors like increased disease activity, certainly corticosteroid usage, can correlate with this. But there are different categories, as one of the speakers yesterday in the abstract session had pointed out, that the majority of kids will have some form of mild depression, although those with more major or somatic depression usually is associated with active disease or possibly on steroids. But it goes beyond just the issues of depression. We have to look at the quality of life overall. So a patient may not necessarily be depressed, but that doesn't mean that they have a great quality of life. And so our colleagues from Cincinnati Children's recently looked at the impact of quality of life, or rather lower quality of life scores and healthcare utilization, and found that those with lower quality of life scores really utilize the healthcare system more and not always in effective ways, increased both emergency room visits as well as psychology visits, so that's a good piece, but still the increased ED visits, hospitalizations, and telephone calls to their healthcare providers. And finally, what does quality of life do, not only on your medical care and your utilization of the healthcare system, but how you interact with your peers? And a recent study showed that over a third to almost half of all children in an IBD practice had some limitations in activities of daily life. And I think one of the things that we always emphasize to our patients, that they live with IBD, but that doesn't mean that the disease should define them. But looking at some of these sobering statistics, it tells us that, you know what, it doesn't matter if that's the mantra that we're telling the families, we're not doing enough. So what is one of the major activities of daily living that we have to focus on in children and teens? And I think we'd all agree it's how you function in school. So Laura Mackner, one of my colleagues at Nationwide Children's, has done a lot of the work in this area and found that pediatric patients with IBD have poor school functioning as well as social functioning, and did look at all the different parameters. The only significant differences noted were in school absences, although they found that the children with IBD also did have decreased grade point averages and overall quality of life. What was interesting, though, is that she found, at least in her study, that the disease factors, meaning the type of IBD, duration, were not necessarily significant predictors of poor functioning. So a more recent study looked at what predictors could be for worse educational outcomes. And so in this study, they age and gender matched children with IBD to controls and found that some of the major predictors included lower socioeconomic status and a diagnosis with some mental health issue, but not the diagnosis of age of diagnosis, duration of disease, the type of IBD, even being on steroids, or the number of hospitalizations, which I found interesting. So again, a real emphasis that as IBD docs that we need to be partnering, or at the very least screening for mental health issues, because this not only impacts the medical aspects of the disease, but how they function in school. So our European colleagues, as well as our colleagues in New Zealand and Australia, have also looked at this. And so, the title of my talk is that we should be using psychosocial development measures rather than chronologic age to determine when we move our patients to adult care. So this study was done in the Netherlands, and what they looked at were different parameters of psychosocial development. And what the authors found were that patients with IBD, when compared to their control cohorts, had significant delays in terms of markers for development of independence. And so you can look at the first box, which are the patients with IBD, the second box, which are the control groups. And some things I want to highlight were factors including significant differences in terms of leaving their parents' home, as well as employment status. And certainly one of the things that we wish for our patients are to do those normal activities that they should be bridging out of as they leave high school, go to college. And this is also telling. So if we're looking at this high school graduation sort of point, this is the time not only when they should be becoming more independent, whether they're going to college or finding a job, but also moving potentially from pediatric to adult care. But if they're still living in their parents' home and don't have the funds, how does that affect how they get their care, and also who actually is involved in the care, i.e. the parents? This study was done as a survey of all the gastroenterologists, both adult and pediatrics, in New Zealand and Australia, and over 40% responded. And so some of the take-home messages when they queried both the adult and the pediatric gastroenterologists were a couple things. They wanted to look at factors which both the adults and peds GI docs thought were important in terms of how you move patients to adult care. The adults identified the most important factors being self-efficacy, and in fact, as we talk about the transition literature, this word is going to come up often. And the biggest barriers that the adult GIs mentioned that they felt were a real hindrance in terms of effectively caring for the young adult patients included poor medical handoff. So that means they didn't get enough information, both medically and surgically, and the patient's lack of self-responsibility. Both pediatric and adult GIs agreed that the most important factor for moving young adult patients to adult care was psychosocial readiness. So it's great that they agreed, but what was really interesting, so you're going to see in the gray bars represents peds, and the black bars represent adult GIs, that when you looked at factors like psychosocial development, the attainment of the appropriate sort of knowledge and milestones, as well as the bottom box of psychosocial maturity, the pediatric GI docs thought their patients had reached those parameters much more so than the adult gastroenterologists did. So, I think a lot of us took at least a few psychology classes. We all remember Erickson. I always love this last phrase: adolescence is not an affliction, but a normative crisis. And so I think our psychology and psychiatry colleagues can interpret what that means. So, you know what? Leaving the safety of the pediatric medical nest is very much in the lay public, as you can see, Wall Street Journal, U.S. News, the Hartford Courier. So everybody's talking about it. So what do? I mean, we can just tell the teens they're so brilliant, why do they need us? But apparently it doesn't work really that well. So the Society of Adolescent Medicine defines it nicely. What transition should be is not just kicking someone out of the nest, so to speak, but really that purposeful and planned movement of the adults and young adults and adolescents who have chronic illnesses from a child to an adult-oriented healthcare system. And our society, NASPGHAN, had a really nice position statement over a decade ago, but it still holds true that it really needs to be a continuum of care that includes normalization of social and emotional development and the acquisition of independent living skills. So let's be blunt. I mean, we all talk about it. I don't know about you all, but between the different committee meetings we've been in, the different talks that we've been to, both our adult colleagues and pediatric colleagues alike agree that transitioning is important. But as we look through the literature, what's really happened to move us to a more effective manner of transitioning and transferring patients. So before we even go further, let's define the differences between transition and transfer. I think often we say, you know what? Johnny is 20, so we're going to transition them to Dr. Doe in the adult GI practice down the road. Transition is not transfer. So transfer of care is moving from one provider to another, but transition is actually that flexible, dynamic process that should start when they are in their early teens or even preteens. I always say that if you have the word teen in your age, you should have already started the process, and timing is going to be crucial. So what are the overall fundamental principles of transitioning? So we need to make sure that the services are not only appropriate for chronologic age, but also development. It's interesting, we always talk about bone ages when we look at growth impairment or growth delay, but in a way, do we sort of have that equivalent of a bone age when we look at a patient? Just because you're 14 doesn't mean that you're necessarily ready from a psychosocial perspective as a 14-year-old. You may be a 10-year-old. The flip side is I think we all know those 13 or 14-year-olds who seem to be wise beyond their years. So just something to remember. And the other thing is I think so often as GI physicians, we focus so much on the Crohn's disease or the ulcerative colitis piece and forget, teenagers have very similar health issues to their peers. Growth and development, sexuality, mental health issues, the struggles with substance abuse. And those are the things that we all have to keep in mind. And knowing, as many of you have heard, it may be amplified further in our IBD patient population. So in terms of transitioning of care in chronic illness, a lot of our colleagues in some of the other areas have done some really nice work. So in endocrinology, they've looked at patients who have type 1 diabetes and found that patients who are in structured transitioning programs have improved clinical markers, including glycemic control, hemoglobin A1C, and decrease in DKA episodes. And even within our GI and hepatology realm, when you look at the liver transplant literature, it's very clear that there's often poor self-management skills and adherence in the young adult liver transplant patients, often defined sort of as that 18 to 25 range, and found that when you had a structured transitioning program, you had improved transaminases and more stabilized immunosuppressant levels in these patients who were post-transplant. So what about IBD? I think we all talk about it. So what's actually there in the literature? So many folks have looked and really recognize that our adolescent IBD patients often have a low baseline knowledge of their IBD and really don't have great access to resources. And so, the question is, how do we identify the deficits and how do we develop effective educational programs that are actually teen-friendly and relevant? And at the same time, I think as seen in that previous study that I showed you from Australia and New Zealand, there's really a poor correlation between what the clinician thinks versus what the adolescent is actually functioning at from a health literacy readiness standpoint. So you could see that there were pretty low correlations in patient-reported self-efficacy in chronic disease management. And I'm not saying that we're clueless as clinicians, but the reality is we may be overestimating how well our patients are doing. And as previously mentioned, we may think we're doing a great job. I don't think our adult colleagues necessarily think we do. And, there have been a few studies that have looked really at the adult perspective of how pediatric GI physicians are doing. And a lot of the things that they cite in these different studies include young adults who have inadequate disease knowledge, lack of self-advocacy, and really don't seem to be fully in tune with what they should do. And so Lori Fishman, I think, has really been sort of at the forefront along with other colleagues in terms of starting to recommend tools that we can utilize to potentially prepare and gauge really how well our teen patients are doing. And again, this is just a sample of some of the things from one of the hate studies that was done at Boston Children's with the adult GI physicians. And you can see some of the areas that are highlighted are the things that adult GIs feel are really important in terms of the medical and social sort of domains in terms of knowledge of disease, self-management, as well as issues where, again, we are not doing a really good job of that really good medical handoff. So, why do you think there's so many barriers? I mean, we all talk about it. We all say it's important. Why is it not happening? I think we can talk about things like resources, both resources at an institutional level, as well as good tools or tracking methods that we can use as physicians. And I think part of the barriers are actually us. I mean, how often do we get attached to our patients? And I think there's that feeling of loyalty that we have to our patients and vice versa. So I think there's so many different things that we need to consider when we really let our young adults sort of fly. So Lori Fishman recently published a recommended proposed timeline. So for those of you who are familiar with sort of the NASPGHAN the guidelines in terms of what we should be doing for transitioning, you can see some similarities. But I liked this because it was actually a nice, clear checklist, basically, that you could kind of go through with your patients and say, okay, you are in the preteen years. These are some of the things that you need to master. Then you're in the early teen years. Here's some more things that we need to look at. Mid-teen, and then, wow, you are legal and you can vote and drive a car, so you really better be doing some of this. But these are the things that we need to be thinking about as we meet with our patients, and not just ask, are you taking your medications? How's your stomach pain, and how many bowel movements are you having on a daily basis? So, I looked through to see what readiness scales there are, and, for the purposes of time, I'm not going to read through everything, but just introduce you to a couple potential types of readiness scales that we could consider utilizing. And one was the track that was originally developed for teens and young adults with as an assessment tool to look at whether they were able to become independent adults. And the major domains with this study looked at self-management and advocacy. Then the same group recently validated it for young adults with chronic illnesses between 14 to 21, whittle it down to sort of the 20 most crucial questions with 5 major domains, including medication management, keeping your appointments and making them, tracking health issues, knowing how to talk to your providers, and managing daily activities. And there are just some sample questions here, so if anybody's interested, certainly I know that my slides may not be on the flash drive. I'm happy to email them to you. Another scale that was developed by my former colleagues at the University of North Carolina and validated through the Chronic Kidney Collaborative has a transition scale, which is a little bit longer. It's 33 questions, very same themes, but in this, the authors really highlight what specific parts of transitioning one should sort of focus on, so not that dissimilar from the Boston group and their sort of timeline of what items that you should be looking at on that checklist, so you can see what you need to be doing as a 12-year-old versus a 15-year-old versus greater than 18. So recently, Jeremy Adler and his colleagues at the University of Michigan administered a self-management checklist by iPad, and they found a couple things. So they found that your self-management skills did improve with chronologic age. So the older you were, you had more skills. Duration of disease actually did not affect the scores, but what I found actually most telling is even though with age you had more self-management skills, your ability to communicate with your medical providers really did improve with age, which is a huge issue. So if you're an independent adult and you don't know how to call your healthcare team, it's going to be a little bit tough to independently take care of your needs. So I thought that was some really good take-home messages there. So what are some educational tools? And so for the next couple of slides, just want to highlight some nice work folks have done. This was done by Linnell Boma and colleagues at Cincinnati Children's. Developed a really nice interactive CD-ROM to help improve teens and understanding their disease. It was self-directed, and what they found is that you really did have improved knowledge in this self-directed program versus, I guess, doctors sort of just talking at you, sort of like that Charlie Brown, the teacher's talking and you're not really listening. I think you actually have to take some active learning. You will hopefully gain more skills. There have been other sort of resources. My former colleagues at UNC me, Maureen Kelly specifically, and some of our nurse practitioner students really developed a nice transitioning book that correlated with the transition scoring system that I talked about earlier. My colleagues at Nationwide Children's have a nice self-management handbook. Again, you can see some of these things, not just transition-focused, but psychosocial issues, adherence, when to call your team. And in fact, I believe this is posted online on NASPGHAN. So if anybody's interested, I highly encourage you, if you're not using this, to check this out. And by the way, our nurse educator, Barb Drobnik, had a nice poster, so you still have some time to go look at it if you haven't. And then finally, I think NASPGHAN did a beautiful job, led by, Dr. Mackner and group, really trying to give guidance to all of us in terms of the different domains that we need to be looking at. And I'm not going to go through every small thing because it's already been touched upon, but again, just reinforcing what's been said. We need to be looking at general well-being, psychopathology, quality of life, social skills, and relationships both within the family structure as well as in school with their peers. So in summary, what are some of the key elements that we need to be doing to really optimize how we transfer care, meaning now we have hopefully done the transition piece, we want to get them to the adults. So again, there's got to be a dedicated healthcare professional within this patient's team that assumes responsibility, and remembering to balance both patient and parent needs. You need to make sure that you know, as the healthcare team, what core knowledge and skills are required for effective transfer so that you do it during that transitioning time period, and you have to remember to address the psychosocial issues. You have to have some sort of transition schedule or educational plan and timeline so there's accountability on both sides, both the patient as well as the healthcare provider. And if you remember, one of the biggest things that we get dinged on by our adult colleagues is that transfer of care and sort of inadequate information. When we always check out to our colleagues when we're post-call, we're expected to give a really good summary. But if we're not doing the same thing for our colleagues who are going to be responsible for the kids that we have diagnosed and shepherded through adolescence, then we're not doing them a service. And finally, having an idea of who you are going to be transferring care to for each of your patients. So what are the future directions and challenges that we need to do as a pediatric GI group? I think one issue is we talk about, in a perfect world, having this wonderful multidisciplinary transition clinic, but the reality is it's not a one-size-fits-all for medication therapy. It's not a one-size-fits-all for transitioning clinics, because there is variability amongst centers in terms of numbers of patients, how the practice is set up, and resources. So, transition clinic may work for some folks. Multidisciplinary transfer of care meetings, either virtual or in person, may work for others. Or at the very least, having established transfer of care summary templates, which I hope in a perfect world can be something standardized that we can all use so that we have some consistency and make sure that we really hit the targets that our adult colleagues and our patients expect of us. And I think as a society, as we move forward, we want to prove to the people that actually give us the money to provide care that it's actually cost effective as well as medically sound and expected to really effectively transition. So figuring out what best scales we should be using for transition readiness, quality of life, trying to look at protocols where we look at real clinical measures like our transplant colleagues, our endocrinology colleagues have done in terms of things like disease activity, progression to complicated disease, utilization of healthcare resources when you have a structured transitioning program, and finally addressing just the cost effectiveness of dedicated transitioning. So thank you for your time.